right, so mitral valve interventions now and in the post-COAPT era. These are my relevant disclosures. So I think it always comes down to the original Carpentier classification. We've learned to think about mitral regurgitation as to two general buckets of disease: primary MR, where the problem is the valve; secondary MR, where the problem is dilatation of either the left ventricle or the left atrium. And there's multiple etiologies for each of these conditions. So I'll split up my talk, though, for primary and secondary mitral regurgitation. And this is a big problem. I mean, MR is 2 to 3 times as prevalent as aortic stenosis. If we talk about severe MR, which is where the guidelines suggest we do have evidence that we should be intervening, we're talking about 2 million people in the United States, approximately split 50-50 between functional and degenerative mitral regurgitation. And we have no shortage of creative approaches that interventional cardiologists and companies have come up with to try to replicate what the surgeons do so well. But of course, we're very limited by what we understand the anatomy to be. We lack, obviously, all the insights from being in the patient. But that being said, we have edge-to-edge devices, and we now have the Pascal device being approved for degenerative mitral regurgitation as well as the mitral clip. We have direct and indirect annuloplasty systems, almost 20 of those, 30 mitral valve replacement systems, and then a variety of other approaches, including neocords, spacers, posterior leaflet replacement, and et cetera. So again, which of these will be optimized for the individual patient is going to be one of the challenges. In terms of clinical evidence and data, most of it has been generated from the MitraClip system and implant, which you're all very well familiar with. And following the negative Everest II trial, which was performed in an era with the learning curve of the MitraClip, but negative, and surgery was substantially more effective than the MitraClip, the MitraClip was approved by the FDA for treatment of prohibitive risk degenerative mitral regurgitation, basically based on a 127 patient parallel registry of prohibitive risk of patients, principally with degenerative mitral regurgitation, led by Scott Lim, showing that patients, as their own control, felt better, had better both mental and physical functioning, NYH class decreased, better walking distances, and perhaps the best data, their rate of heart failure hospitalizations in the year before to the year after the MitraClip substantially fell. And this is reflected in the guidelines, the most recent guidelines. You can see, looking at mitral TIA recommendations for severe primary MR, we have a class 2A recommendation for severely symptomatic patients at now high or prohibitive risk. So the guidelines have now recognized kind of what they call high risk as well as prohibitive surgical risk patients. And the recommendation has gone from a 2B, which it was several years ago, now to a 2A, I suppose, just reflecting more general experience and in consistently good outcomes in these very high surgical risk patients. The newest player that we have is the Pascal system, which has been recently approved by the FDA for treatment of degenerative MR based on the Class 2D trial. This is a MitraClip similar system, but has paddles instead of grippers, which are somewhat wider, has a spacer, which will fill some of the coaptation gap, and some other modest differences. When you look at the non-inferiority trial that was done and the preliminary data that's been released in the first 180 patients, we saw non-inferiority for the primary safety endpoint of composite major adverse events at 30 days, 3.4% for Pascal and 4.8% for MitraClip in these high-risk DMR patients. We saw non-inferiority for primary effectiveness, which was MR less than or equal to 2+ at 6 months, which was 96.5% for Pascal and 96.8% for the MitraClip. And when you looked at the major clinical outcomes, including death and heart failure hospitalization, they really looked pretty superimposable. So we'll need to get a larger data set, and we'll need to have a lot of experience to learn which patients may benefit preferentially with use of one or these other devices in degenerative mitral regurgitation. Now, with increasing experience with the MitraClip, there's a lot of interest in trying to bring it into intermediate surgical risk patients, and there are 2 trials that are ongoing. The one that's farthest along is the Repair MI trial, 500 patients with 3 to 4+ degenerative MR and moderate surgical risk, as defined here, randomized to either the MitraClip versus mitral surgery, with a total of 10-year follow-up, again powered for non-inferiority. So now if we switch to functional mitral regurgitation, The trial that we were privileged to run with Mike Mack, many other people in this room, was the COAPT trial. The largest trial to date in the mitral space of 614 patients with left ventricular dysfunction and secondary MR, ejection fractions of 20 to 50%, with a capped left ventricular end systolic dimension of 7 centimeters on maximally tolerated guideline-directed medical therapy, randomized 1-to-1 to MitraClip versus medical therapy alone. You all know this data. At 2 years, there was a marked reduction in the primary endpoint of heart failure hospitalizations. There was also substantial benefit that was increasing over time with a reduction in all-cause mortality, with the number needed to treat of about 6 patients to prevent 1 death within 2 years. A substantially lower number needed to treat than for medical therapies. Patients felt better, they had better functional capacity, and this is one of the safest procedures that we do in the cath lab with, as you just saw in the last case, the patients are boringly stable in most of the cases with very low rates of device-related complications. We now have the 3-year data as published by Mike Mack, and as you can see, death or heart failure hospitalization at 2 years, now spreading and diverging out to 3 years. And I just show you this ridiculous p-value with 10 zeros and a 1 out to 3 years, just to make the point that there's no doubt that this is beyond a statistical shadow of doubt. So in the COAPT patients, there's marked benefit in terms of both improved survival and reduction in heart failure hospitalizations and all the other benefits. There's no chance, this is chance. So the final 5-year data from COAPT we've submitted as late-breaking trial for the ACC 2023. Hopefully that will be accepted and we'll be able to publish it simultaneously in a major journal. The guidelines reflect the results of COAPT, basically suggesting that for patients meeting COAPT criteria, there's a 2A a level of evidence B recommendation for such patients. But what about the role of TEER in COAPT ineligible patients with secondary MR? And I'll point out severe pulmonary hypertension or RV dysfunction, atrial functional MR, all excluded from COAPT, end-stage heart failure, acute cardiogenic shock. And what about moderate mitral regurgitation without left ventricular dilatation for preventative treatment? Well, we need randomized trial data in all of these areas. We're starting to get some registry outcomes in some of these patients. Just published a few weeks ago in JACC was this registry from the STS ACC TVT registry of about 3,800 patients over an 8-year period with shock that were treated with MitraClip. And of course, there's no concurrent control, but they did note that the outcomes, both in terms of mortality and freedom from heart failure hospitalization, was substantially better if the MitraClip procedure was successful, which was the case in about 86% of patients, compared to if it was failed. Obviously, this does not improve causality. We need randomized trial data. I don't think all these patients were acute cardiogenic shock. A lot of limitations to this study from this administrative database, but it certainly is hypothesis generating. And there is a randomized trial, the Capital MR study, which is ongoing in acute cardiogenic shock and severe MR. We also have the MITRA Bridge multicenter registry of more chronic patients with end-stage heart failure as a bridge to transplantation. A variety of patients treated in this, and the bottom line was that about a quarter of the patients, once they got treated with the MitraClip, improved sufficiently so they no longer even needed listing for heart transplant, and the mortality was relatively low, 4.5% in these mostly bedridden patients. Outcomes overall looking good, but again, we need randomized trial data. Again, heart failure hospitalizations seem to be more than 50% reduced in the year before compared to the year after the MitraClip. Interestingly, and maybe Bob Bono would want to comment, the European guidelines, I think, have addressed this issue 1 year later than the US guidelines, and actually, in addition to a class 2A recommendation for basically patients with COAPT criteria and functional MR, give a class 2B consideration for a mitral TEER for selected cases in which the operators with level of evidence C believe there may be some benefit to reducing severe mitral regurgitation. Saibal, I think this is you. I'm going to call them back later. So that is interesting that they do give a class 2B recommendation for some of these other situations. And I think there's no reason to think that it wouldn't work, for example, with left ventricular ejection fraction of 55%. And the pulmonary hypertension data up to 70 millimeters of mercury looked very, very good, et cetera. And then finally, what about all the new devices to treat mitral regurgitation? Well, I think that, while we were obviously pleased that COAPT was positive, I don't think anybody, including Mike and myself, thought it was going to be as positive as it was. And this does have major implications for the new devices for mitral regurgitation. For competitive mitral valve repair technologies, will they be as safe as the MitraClip? Will they be as effective as the MitraClip? Will they be as durable as the MitraClip? Because the MitraClip actually treats the pathophysiology of secondary MR, which is lack of coaptation. Will they be able to treat the same or different patients, such as MAC, wide or multiple jets, extreme tethering, small annuli, etc.? Will they be able to treat MitraClip failures or recurrences? Or will the MitraClip be able to treat their failures or recurrences? So there's a lot of room for complementary treatment here. For mitral valve replacement technologies, which we are touching on, the real question is that given the likelihood of greater procedural complications and the need to anticoagulate valves, these technologies are going to need to be shown to be more effective than the MitraClip or be able to treat MitraClip ineligible failures. And again, we have one randomized trial going on and a couple registries in this field, which hopefully will provide more insight into these important questions. Thanks very much. Well, right. Well, that's that 2+, 3+ MR group, again, without any, major effect on the left ventricle yet. The ventricles haven't dilated, and there may be a role to treat those patients. In COAPT, 86% of the patients got in the trial because they had either pulmonary systolic venous flow reversal and or an EROA of greater than 3 centimeters squared, so 30 millimeters squared. So I think that that's the bulk of COAPT. Some people who didn't have one of those criteria got in because they have 2 other criteria, being a contractor with, et cetera. But you're right. I think that ratcheting it down and looking at more moderate to moderate severe MR in healthy patients.
Now for severe MR is an ERO of 0.4.
Right, but again, it was COAPT was 3 to right. Right. Yeah. Well, 30 millimeters squared I think is fine for ERO. It's 3+ or 4+, which was COAPT.
Greg, I just
Bob,
want
I just wanted to ask you. I'm sorry, Dave.
No, you go ahead, Bob. Ask Bob anything you want. I ask him stuff all the time.
Well, I was going to ask Bob again what you thought about the European guidelines giving the 2B recommendation for some of those other situations.
Yeah, no, it can be done, and I think it's like any the guidelines. I think we could do that in this country too. If you have a patient who's really sick.
Can we hear you better?
A guideline, just a guideline, and a 2B makes it, opens the door. But you could take U.S. guidelines and still use your clinical judgment, whether it's guidelines recommended or not.
Right. And it doesn't say class 3 for those situations.
Yeah, Greg, I'll make one
Dave?
comment and one
Yes.
question. My comment is about, we have to be a little bit careful about intervening them for moderate MR unless we can first agree that mild MR is the endpoint we have to get to. Because I don't think we can in one trial say moderate MR is okay, another trial we're going to intervene and randomize moderate MR. I can't do the math on that. That's a comment. My question was about your last slide where you said TMVR needs to beat MitraClip. Why in the world would it have to have a superior outcome? We didn't play that story with TAVR. We compared a surgical valve that didn't need anticoagulation. We didn't know what gradients would be. We didn't have that sort of editorial comment. So I was curious about that. I get it could be equivalent. Maybe there'll be advantages to both. One less anticoagulation, one less MR. Who knows what would happen, but why would it have to beat it?
Well, everything is safety versus effectiveness, right? So if you are less safe, then you generally need to be more effective, and that's the FDA view and most clinicians' view.
But
Let me answer. The question is, okay, that the MitraClip is so extraordinarily safe, okay? So if you have a 2 to 3% incidence of left ventricular outflow tract obstruction or hemolysis or major bleeding on anticoagulation, which might occur within the first 6 months, you've got to have something to overcome some of those complications. And there's no doubt that TMVR is going to essentially eliminate mitral regurgitation. Will that lead to an improved outcome?
Oh, no, but that's what I mean, Greg. All I'm suggesting is I think they need to be equivalent. They don't need to be better than. In other words,
if it's less safe, it needs to be better.
No. I didn't. But again, I don't want to make an assumption yet that it's going to be less safe. And I also think this is where I like getting data, because I do think we'll learn something. In New York State, we're just starting to unpeel it, but the mortality rate for for MitraClip was 3% in 2019. The risk of mitral valve replacement was 2.5. Again, we're starting to peel back the onion and figure out what we're looking at, but I wouldn't make these assumptions that it's quite as safe as it is in clinical trials. In the long term, we'll learn that, and that's why I said I think all these procedures should be done with low mortality once we get to end state, once we get to where we need to head, just like we did with TAVR.
Well, to start to answer that question, and I totally agree with you, we don't know the answers. We don't know it'll be less safe. We don't know it'll be more effective. And that's why it's so essential to get randomized clinical trial data, to look at those two sides of the equation.
Instead of a single arm.
If we have a single arm study, we just don't know what the outcomes would have been with the MitraClip. So I hope people will randomize.
Greg, if I can just go back to that 2B, because you made me think on my feet, and I didn't address the other aspect of that, is that the U.S. guidelines do have a 2B for atrial functional MR,
For atrial
which may be the same kind of patients they're
Right.
talking about in Europe. So that
Right.
we actually do have a 2B for atrial
Thank you.
functional.
And there was a study on that in the EXPAND registry, in the sub-study.
Right.
That showed that it
That looked good.
effective.
Well, we gotta keep on time.
Okay.
Okay.